Welcome from CVI2017. I'm Dr. Michael Luna here with Dr. Mrinal Yadava from Oregon Health and Science University. We'll be talking about acute coronary syndrome from external compression of the left main coronary artery. Welcome.
Thank you, Dr. Luna, and to everyone behind organizing this meeting. So I'd like to talk about a case that I saw kind of in the beginning of my fellowship, and it served as a good learning experience, and I'd like to take some of your time and discuss that with you guys as well. So I'm from Oregon Health and Science University, and these are my accomplices in this case, Dr. Atkinson and Dr. Tibayan. I don't have any disclosure, any conflicts. So diving into the case here, this is a lady, 51-year-old with chronic hepatitis C, pulmonary fibrosis, and resultant pulmonary arterial hypertension on chronic supplemental oxygen at home, who presented with sudden onset dyspnea and chest pain. The dyspnea was more so than her usual. In the emergency department, the character of the pain was, when it was assessed, was very atypical for myocardial ischemia or angina. It was non-exertional and pleuritic in character. The only other bit of history on this lady is that she's an active smoker and has been a smoker for a long time, no other illicit drugs or alcohol. The initial exam on presentation demonstrated tachycardia, tachypnea, and hypoxic respiratory failure requiring supplemental oxygen with a non-rebreather mask. She was otherwise alert and oriented. She was in some degree of respiratory distress. On the cardiovascular exam, there was just a faint systolic murmur at the left upper sternal border, and she had an elevated jugular venous pressure with a prominent V wave. The respiratory auscultation was positive for fine inspiratory crackles, kind of in keeping with interstitial pulmonary fibrosis. The initial ECG that was obtained in the emergency department is up right now. So this is basically shows sinus tachycardia, and there are some STT changes that were different from her baseline ECG, especially in the precordial leads and the left side of leads. There's a little bit of T-wave inversion, and so basically just an ECG that is concerning for ischemia. So at this time the patient was hypoxic and was requiring higher degree of supplemental oxygen, and the initial troponin was 3.4. So at this time the patient was in the ED, and based on her tachypnea, tachycardia, and the atypical nature of the pain, the possibility of acute pulmonary embolus was considered to be on top of the differentials, and so CT chest with angiography was obtained, which ruled out an acute pulmonary embolism, but it did demonstrate diffuse ground glass opacities with some degree of bronchiectasis, and there was straightening of the interventricular septum, which was suspicious for elevated right-sided filling pressures. During this time, the patient had received one sublingual nitroglycerine tablet, which caused her pain to be significantly mitigated. So again, considering that the story, it wasn't a home run ACS, in spite of the ECG findings, in this construct, we thought an echocardiogram might be useful. And the echocardiogram findings were very suggestive. As you can see, there's just one still, a short axis view through the LV, which shows that the septum and parts of the anterior wall, anterior septum are not moving and thickening as briskly as you'd expect. The EF, which had been normal on prior visits, was a little bit reduced, and as you can see, there are wall motion abnormalities that concern one with regards to the LAD and left main system. The right ventricular systolic pressure was 68, as one would expect, and it also demonstrated on the RV-OT views dilated main pulmonary artery. So at this time, it was a pretty straightforward next step. We took the patient to the cath lab and obtained a coronary angiogram. And as you can see, the picture on the left is a video of the coronary angiogram. There is pretty evident bird beaking, or kind of the tapering off at the tip of the left main, suggestive of left main osteal disease. The right image, again, just a different view, which doesn't project the best, but again, essentially corroborating our finding that there is osteal left main disease. So at this time, we paused, as one would hope to do when one finds left main disease. We got the patient's outpatient pulmonologist involved and the cardiac surgeons involved, and it was felt that due to the patient's pulmonary issues and ongoing hypoxic respiratory failure, in addition to the other comorbidities, body habitus, those kind of things, that her surgical risk would be quite high. And so a plan for high-risk PCI was done. We placed a balloon pump in the left femoral artery, and using a XP LED guide catheter, the left main was engaged and balloon dilatation was undertaken. At this time, we did an intravascular ultrasound, which demonstrated a very peculiar picture with very little atherosclerosis throughout the left system. And the images A and B up on the screen right now demonstrate a slit-like narrowing in the left main ostium, which is a classic, well-described finding seen when there is external compression of a coronary artery, particularly the left main. So this, in keeping with her history of pulmonary artery disease, a known dilated main pulmonary artery, and the absence of significant atherosclerosis, kind of nailed the diagnosis for us in that everything pointed towards external compression of the left main, which again raised questions about the ideal interventional strategy. So at this time, given her presentation with hypoxic respiratory failure and ongoing decompensation, we decided to place a drug-eluting stent, 4012, in the left main. And these are the images coming up in a second. So, all right, and at this time we also reviewed the initial CT that was done to rule out a pulmonary embolus. And interestingly, this hadn't been reported by the radiologist, but we did find evidence of that dilated main pulmonary artery pressing upon the left main coronary artery, and this further helped us and informed us in our intervention. And this was actually reviewed prior to the actual PCI. After this, again, a repeat IVUS was done, which demonstrated good stent apposition. You can see that that slit-like narrowing seems to have been opened up, and we had good luminal area on the post images. This is the coronary angiogram done after intervention, and this demonstrates, again, good angiographic result with TIMI3 flow down the artery and no evidence of any complications. The patient was transferred to the ICU, and the balloon pump was removed shortly after. And the patient was actually, she was treated, and her respiratory failure did respond with the coronary intervention, and the patient was discharged in hospital day 6, and it's about 2 years now, and I've seen her in follow-up a couple of times, and she has been doing well, and in the process quit smoking. So that's an unrecognized side effect. I'd just like to take a couple of minutes here and discuss a little bit that is known about extrinsic compression of the coronaries. So in cohorts of patients referred for, with ASTs referred for interventional assessments, coronary compression has been reported in between 5 to 18% of cases. The majority of these are by dilated main pulmonary artery, which is seen in congenital heart disease, pulmonary artery hypertension, as in our case today, and artery aneurysms. There have also been reports with bronchogenic cysts, malignancies, and abscesses. Different people in different series have looked at the predictors for whether the cause of myocardial ischemia is coronary compression. And the general trend is that, as you would expect, a large pulmonary trunk and a pulmonary trunk to aortic diameter that's increased, the normal is 1. A predictor would be 1.2 or more in one study. And in another study, again, the pulmonary trunk to aortic diameter was a significant predictor, and a narrow left main takeoff angle was another significant predictor. So these different things, different measures and predictors that you could use from non-invasive imaging could inform you about the etiology of myocardial ischemia. And just a last slide about if one were to find this situation, the diagnosis, obviously coronary angiogram would be the gold standard, with IVUS and OCT acting as useful adjuncts. It's important to differentiate this from atherosclerotic disease because the management could be different. The classic description on intravascular ultrasound, as in our case, was a slit-like narrowing rather than atherosclerotic disease. And as one would expect, MRI, CT, and TE can be used adjunctively to assist in making this diagnosis. The optimal revascularization strategy in these cases is still unknown, related to the rare nature of this condition. In left main disease, one would traditionally prefer bypass surgery, but these patients often have pulmonary disease and comorbidities which may preclude preclude good surgical candidacy. So PCI for unprotected left main, which is a 2B revascular guideline for atherosclerotic disease, one could extrapolate that and use that for extrinsic compression. And there have been a couple of studies which have looked at PCI for left main compression, which have demonstrated good short-term outcomes. But again, long-term data is lacking, and there are concerns, especially related to stent restenosis or fracture if the external compression were to continue. And that's all I have. Thank you very much.
All right, great. Back to the surgical option that these patients have. The comorbidities for sure increases our risk for that approach, but also these lesions probably have some dynamic component to them, and the question would arise of whether grafts would even take in those patients, and so that's an important consideration. And I think probably you're right that PCI does best with these patients. Now, was there any consideration for a larger French catheter in case you all did dissect and ran into complications?
Yes, there was. This was obviously a challenging case and kind of in a data-free territory. We did use a balloon pump to help us and help us out. As far as I can recollect, there wasn't really. We felt that with the balloon pump, with what we knew about our hemodynamics, that the interventional cardiologist who was intervening was reasonably comfortable with the setup that we ended up using. I think based on the hemodynamics on the balloon pump, we felt reasonably comfortable.
Good. Now, there's always a possibility when we're dealing with these that these recompress, as you mentioned a bit more. It's tough to get a big experience from a single center because these are exceedingly rare, as you know. But was there any discussion or consideration for following her with coronary CT angiography to make sure that that's not happening with the stent? Because the radial strength of, as you know, of a coronary stent may not be enough to prevent compression of it. Yep.
That's a very good point. Stent fracture from the radial compression is a valid concern. At this time, she's had repeat CT scans for her pulmonary disease, and we've looked at the main pulmonary artery. We've been careful in measuring the size, and since this procedure, she's actually quit smoking and got established with the pulmonology clinic and has gotten good therapies. And we haven't seen any increase in the size of the main pulmonary artery. I can't speak to the utility of CT, coronary angiography, and those kind of things in this particular situation. I think it's on a case-by-case basis.
Right, yeah. It's just something, a good thought, I think, to have, especially if patients are doing well from a pulmonary standpoint. They're going to have a good long-term outcome to surveil them. Thank you so much. Great case.
My pleasure.